Good afternoon, everyone. Thank you for being early for the Roche webinar. Let's give the other attendees a few more minutes to join us before we begin this session. Meanwhile, if you're facing any technical difficulties or if you cannot hear me well, please send us a message at the chat bar below and the HIMMS staff will assist you. Thank you. A very good afternoon again, everyone. Thank you for being punctual and for joining us today at the Roche webinar. So without further ado, please welcome our moderator, Dr. Charles Alessi, Chief Clinical Officer at HIMMS. Charles, the floor is yours.
Thank you, Brendan, and good day, everyone. I'm Charles Alessi, and it's my greatest pleasure to be here today. For today's session, I'm joined by Professor Shyong, Director of the Center of Excellence for Chronic Disease Prevention and Management at the National University Hospital System in Singapore, Farid Bidgoli, who's the General Manager for Roche for Thailand, Myanmar, Cambodia, and Laos, and Chuah, who's the former Director General of Health and Chief Executive of the New Zealand Ministry of Health. But before we get started, I'd really like to get us to think a little bit. And I'd like to get everyone's opinion on the following question. What do you think is the most critical enabler towards moving forward to preventative health? And we have the questions out in the quick poll ahead of you. And the potential answers are research, real-world data and evidence, that's the first one. Data access and interoperability is the second, and digital healthcare solutions like telemedicine is the third. So please take your time, select one of the options and click submit in the pop-up window that you see. So we'll wait a minute or so and then we'll close the poll and we'll come back to that a little bit later. But in the interim, I think we'll start by asking each of our panelists to introduce themselves. So I'll start with Professor Tai. Could you please introduce yourself and give us and really tell the audience why you're here today?
Thank you very much, Charles. Well, my name is Shyong. I work as a physician in the National University Hospital, mostly looking after patients with diabetes. In the last 5 or 10 years, I've begun to sort of be involved in asking the question, how do we prevent diabetes? And in fact, how do we engage our patients to make the changes that they need to make to improve their health? And that's really why I'm here today. I mean, when I was offered the opportunity to come and speak, I thought it would be nice to be able to share some of those thoughts and experience.
Thank you, Shyong. Thank you very much. Let's move now to Farid Bidgoli.
Thank you, Charles. Good morning, good afternoon, good evening, wherever you are. My name is Farid Bidgoli. So I've been in the pharmaceutical industry for over 20 years, and I have worked in many different markets, UK, US, China, Iran, and now, fortunately, in Southeast Asia. During my career, I've had the pleasure of working with some of the top global technology companies, such as Microsoft, Amazon, and Google and Verily. And I think what's become personal to me is around about 7 years ago, I lost my grandmother to non-small cell lung cancer. And when I was reflecting after her death, I was thinking about the data that could have enabled a faster diagnosis, the tools and the digital health solutions at that time, 7 years ago, that could improve her experience of care. And, you know, the future was there then, it just wasn't evenly distributed. And I think COVID has enabled us to maybe more evenly distribute some of those technologies and some of those solutions, but it's still not distributed evenly everywhere. So it's a subject I'm really passionate about, Charles, and I'm glad to be here with you today.
Thank you. I think it's a subject we're all passionate about, Farid. It's really what we should all be thinking about. Thank you. And now moving on to Chuah.
Hi, Charles. Thank you, everyone. Hi, everybody. Hey, my name is Chuah. I live in New Zealand. I've spent 2/3 of my working career working in healthcare. And 3 years ago, I finished up as the Director General of Health in New Zealand. And these days, I have the luxury of picking and choosing what are the areas of interest that I would like to contribute my time in. And I thought I would share this with you briefly. One is I'm interested in what does the future of healthcare look like? And that's really why I'm here today. And secondly, of course, is I'm also interested in the leaders we need to be able to make the transition. And finally, it's a bit more personal, is what does better care options look like for the elderly? That's very personal because my mother is 89 and I'm 63. And the most interesting part, having thought about this particular issue, is I've just had a granddaughter. So I'm really thinking about the world that she will live in when she reaches 63. So that's why I'm interested in the topic we're going to discuss today.
Wow. I mean, that's really why we're here. So thank you ever so much for that. So we got a bit of time today, so let's use this really as constructively as possible. So of course, let's frame what we're going to talk about today, because unless we do, we'll just launch into nothing. And I think it's let's try to keep that as tightly as possible. So I'm really going to give 3 what I call truisms, which really has accelerated the process of personalization to the degree it has at the moment. The first truism is really that COVID has accelerated digital transformation in health and care. I don't think anybody will disagree with that. You know, if anything, it's the unexpected consequence of a complex adaptive system that happened, but it did happen. And in this terrible pandemic, it's probably the only good thing that happened. Secondly, it's really opened the door to a lifelong course in terms of the management of non-communicable diseases. Shyong mentioned diabetes, but of course, cardiometabolic disease is also connected. So it really opens the door to us managing these diseases in a fundamentally different way with the participation of the individual. And the third truism is that we've really moved from the days of the 90s, where we were talking about evidence-based care for populations, even though that's as important, to really talking now more about personalization of care. And this takes us directly into this new wonderful world we have, where not only do we have precision medicine, of course, and we know an awful lot about that as we're developing these processes, therapeutic interventions, to really treat people once they develop symptoms, but also precision health. And precision health is really where one's looking at delivering nudges, delivering behavior change to individuals to manage their risks better, not to get into a stage where they have symptoms. So it really is the equivalent of a perfect storm. This is really where things are happening now. And I think this is a really exciting time for us to be considering this subject. So that's enough gabbling from me. Let's really start listening to what our panelists have to say. So let me welcome Chuah for his presentation to start with. Over to you, Chai.
Okay, I'll just bring up my presentation. Just a minute. Technology is always like that. It doesn't work when you want it to work.
No, it works. It's only that we're not as good at it as others.
Here we go. Okay, so I'll be brief. I've got 8 minutes to talk to you about this. So I'm going to cover 4 things. One is COVID-19 as a catalyst for reform. What does a post-COVID health reform themes can look like? That brings us to personalized healthcare. And I'm going to zero in on a particular piece of work that was involved in called the PHC index. So let's go. So let's start with the COVID-19 catalyst. So many in the participants would be very familiar with this. When COVID-19 hit, it really exposed the malaise of many healthcare systems with deadly consequences. Most health systems are analog, they're siloed, they're fragmented, and the response to change is glacial. The other thing that COVID-19 has also exposed is the way that we continue to have a linear response to an exponential threat. So if you look at the mainstream response to COVID at the moment, it is about lockdown. And it is about significantly pausing all the other health services so that we can focus on COVID. Now, as someone was saying, in our interest to focus on safety, we have almost put aside well-being. But there is a silver lining with COVID-19. And as Charles has alluded earlier, it has really forced the issues around what I call many of the stalled innovations, things that were there, sitting there waiting to be given some sort of impetus. So genomic sequencing, platforms being used for vaccine development, the exponential use of wearable and apps, point of care solutions, and virtual care, just to name a few. So these things, which has been stalled for quite a long time by most healthcare systems, but with COVID-19, there is actually no choice but to really accelerate all those things. So that's a silver lining. The other thing about COVID-19, it actually highlights the significant sacrifice that frontliners and the general population, especially those living on the margin, are making. If you look at our frontliners, I mean, many of the things that work is largely because of the goodwill and the heroics of our frontliners. But I think despite those efforts, we see day to day around how those who live on the margin continue to actually be victims of this pandemic. So COVID-19 will force reforms of health systems. So in my mind, these are the themes that need to bear in mind for countries who are looking at reforming their health systems. It needs to move towards well-being and resilience. It needs to look beyond the issue of health. For a long time, the healthcare sector has talked about looking at broader determinants of health. Well, here they are. So we need to actually look at the social issues, the economic, and more laterally, the issues around the environment. The themes also has to look at early prevention and detection. And the fourth theme is kind of really important because it needs to actually push health system towards looking at self-care, home care, community care, and primary care. And finally, which is really the subject of our discussion today, is the future of healthcare and reforms of healthcare needs to have a very strong theme of personalization. If we look at personalized healthcare, I think we might spend some time later on to look at the definition of that, but in my mind, there are a number of characteristics when we talk about personalized healthcare. Personalized healthcare has an element of precision. That is, we want to be very precise about what is wrong with you and what has caused it. It also needs to be very exact. It needs to be very specific of the location of the system and the determinants of interest. It needs to be tailored when it comes to issues of prevention, of monitoring and treatment and rehabilitation. And when we get to the treatment, it needs to be very specific. And treatment also needs to be earlier, and treatment also needs to be smaller. And last but not least, I think personalized healthcare will be highly individualized. What it really means is that to design a personalized healthcare for an individual that looks at the broader determinants of well-being that is unique to the individual. That really leads me to the agenda of the personalized healthcare. So there needs to be a global dialogue, both at a national and international level. The dialogue needs to be deliberate, it needs to be focused, and also needs to be collaborative. And that's partly the challenge. Part of the dialogue is the discussion of the need to have a strategy for a personalized healthcare ecosystem. Because without a strategy, what's going to happen in our dialogue is going to be lurching from one piece of jigsaw puzzle to another. There are many starting points for such a dialogue, and I was privileged to get involved in one of those dialogues, an initiative called the Personalised Healthcare Index, which was actually sponsored by Roche, and that got released in January 2021 in the APAC region. So the Personalised Healthcare region really is trying to, if you like, draw out the fact that for personalized healthcare, there are a number of important, in this case, it was called vital signs. We can call it whatever it likes, right? But what it actually signifies is that there are, for the ecosystems of personalized healthcare, there are multiple variables that are very important. Now, in the case of this Personalized Healthcare Index, there were 4 vital signs, which are put up on the slide here. And there, behind each of the vital signs, there was an attempt to develop measures of how we would actually measure the progress that various jurisdictions were making towards those vital signs. And eventually then we gave a score. Now the purpose is actually not to start an arms race, but to actually stimulate a meaningful dialogue. So this is my last slide. So if we look at the journey ahead for the agenda of personalized healthcare, it will kind of follow an exponential trajectory, which means that when we start, it will kind of look at quite slow, but then it will really pick up really fast. And it will have what I call a hockey stick trajectory. But the personalized healthcare will face some familiar challenges around the issues of access, of affordability and equity. And we mustn't forget that lens. It will face new challenges as we look at personalized healthcare around cyber attacks and ransomware. And in the country that I live, this is very real because one of our big hospital systems has been crippled by this for a month now. But personalized healthcare will need to bring with it new models, both in services as well as in business, and also new tools and new processes. But those new models, tools, and processes requires new culture, new network, new talents, capacity, and capability. And there's no doubt in my mind, finally, that digitization, information technology 4.0 or 5.0 will play a pivotal role. Thank you very much.
Wow. Thank you, Chai. I mean, talk about provoking us all to be thinking in terms of the new world. I mean, that's just fantastic. Thank you ever so much. We'll come back to all this, of course. Let me now pass on to Farid. And before I do, actually, I better disclose the fact that I've known Farid for so long that he was probably still in shorts because he hadn't graduated to long trousers the first time I met him. And I was a crazy young physician. So Farid, now's your chance. Over to you.
Thanks, Charles. It certainly wasn't that long ago. Let me share my screen. Okay, so what I'd like to discuss today really is what are we aiming to do in healthcare? Are we aiming for personalizing healthcare, or do we want to personalize healthcare? Because those things are totally different. And I want to give you that from a Thailand perspective and share with you what's going on in one of the major economies in Southeast Asia. So Thailand, like many countries, actually has a national strategy. In fact, it has what it calls Genomics Thailand, and is part of the economic strategy to grow Thailand over the next 10 years. And actually, this strategy in its entirety was recognized by the Futureproofing Index that Chai just mentioned, in the fact that actually Thailand with Taiwan was ranked as the #1 for having the best health policy and strategy for personalized healthcare, which sounds fantastic. And in fact, one of the core elements of the strategy actually built on the UK's 100,000 genome projects is the fact that they want to build one of the largest biobanks in Southeast, well, in Asia specifically, and screen over 50,000 genomes. With that, it aims to develop risk scores, and it wants to drive towards preventative medicine. And basically, Thailand is known as being an excellent from a medical tourism hub, and it really sees this as a key differentiator as well, to really strengthen its position using personalized healthcare to enable that. From an economic perspective, then I think the estimated market in Asia for personalized healthcare and genomics is estimated around about $38 billion. And they've also looked at the savings this could deliver in healthcare. And let's not forget, Thailand does have a universal healthcare system, which is one of its key successes. And it believes that it can save up to $2.2 billion by implementing personalized healthcare through, like you've said, improving screening and diagnostics much earlier. So how is it doing on that? Great strategy. How's it doing? Well, I want to understand whether does Thailand have a personalized healthcare strategy, or does it have a plan? And the reason I say that is if we look at this data that's actually published by The Economist in the Cancer Index, to the left of your screen, you'll see that Thailand's highest incidence, actually the biggest cause of death is cancer within Thailand, and the highest prevalence is lung cancer. And in fact, it's the second most common cause of death out of all lung cancers. Now, what we know about lung cancer is it's not just one disease. In fact, we know that actually there's 13 common genomic mutations, which allows a personalization of healthcare to be delivered in that setting. But what we can clearly see, though, is that in Thailand specifically, that strategy for genomics healthcare, Genomics Thailand, does not have a research component looking at lung cancer. It doesn't have differential investment, specifically in terms of targeted therapies in lung cancer. And therefore, is it a strategy? And does it need a plan? And to further substantiate that, then what we can see is there was a paper published by Chulah University, one of the most prestigious universities in Thailand in 2019. And it had to look to see which personalized technologies available in lung cancer, in cancer specifically, but here you can see the data on lung cancer, was available in the National Clinical Cancer Network guidelines. These are international guidelines. And what it found that out of over 20 medicines available to treat cancer in a personalized way in the universal healthcare system, there's one medicine available. And therefore, it's not surprising then in the Futureproofing Healthcare Index, as you can see here in red, that Thailand actually ranked the lowest out of all Asian countries that were in that index. And the fact that the recommendation is that they need to invest more in personalized technologies. So I think in summary, when we look at a national strategy perspective, Thailand it's got a great strategy, but unless it really resources that strategy, unless it really thinks through strategically how it aims to deliver that strategy, then all it ever will be is a strategy. On a local level, though, there is shoots of hope. And I want to kind of share with you that there's a collaboration here between Rajaviti Hospital in Thailand, in Bangkok, and they wanted to use artificial intelligence to really understand, could they, via chest x-ray, detect COVID-19? And they actually did a trial comparing the radiology interpretation of the chest x-ray and then radiologies plus AI. And then they compared that to a PCR test to demonstrate what was the accuracy and to train the algorithms to really improve that. And actually, they're not just using that now as a piece of research, they're actually in their second assessment of the accuracy of the artificial intelligence algorithm to detect intervention. And they've developed a pathway whereby they hope that in the very near future, that they'll be able to screen patients in this way to detect COVID-19. So that's, you know, a really great shoot in terms of being able to take a national strategy and localize that to improve outcomes in healthcare and drive efficiencies in healthcare. And what we see is there is an interest in artificial intelligence. As we were to look at just related publications in Thailand, we see a huge advance in the startup community. Everyone is talking about AI, and I think the momentum is definitely there. But for me, what's really important is personalizing healthcare. And I want to share something that actually is quite inspiring. There's a company called Willala, and this is a small-based startup company in the south of Thailand in a region called Pattani. Now, Pattani is not a tourist destination. It's not Koh Samui, it's not Koh Phangan, it's not Phuket. And in fact, it gets very little investment from a knowledge economy in there, but there's a small startup. And what they decided to do is that they offer a buccal swab and they test your DNA. And within 45 days, via their digital Willala app, they actually share with you which foods they recommend that you should eat and which foods to avoid. And that is personalized healthcare. However, they started to think, how could they personalize healthcare? And they took it a step further. And what they did is they started to partner with restaurants and chefs. And they said, if a patient brings their app with the foods that they should avoid and the foods that would benefit them, would you be able to personalize a menu and cater for them? And in fact, they've got actually 40 restaurants across Thailand signed up to do that. And that really is personalizing the healthcare experience. Another great example of personalized healthcare experience is with Siriraj. Now, Siriraj is one of Southeast Asia's biggest medical facilities. It actually has over 2,000 beds, and it treats every year over 3.8 million patients. Well, develops 3.8 million services. And one of the things it started to develop in 2019 was something called Siriraj Connect. And this is a healthcare app designed to help patients and be, let's say, the epicenter for telemedicine and telemonitoring and teleservices. But actually, when a patient travels to the hospital to receive an outpatient or an inpatient service, if the clinic is behind, the patient will get an alert and it will tell them to go to the nearest coffee shop. Now, that's really personalizing the service for that patient, making them not wait in a waiting room. But if we take that story further, and what I really think, when we really think about personalizing healthcare, is on the right-hand side of your screen, this is a picture taken from their tele-triage center in Siriraj. And they found that actually that the population that they interact with is mainly elderly people. And that actually, in terms of reassuring elderly people and talking to them, obviously, they wanted to make sure that the person on the end of the phone was aware of their vocal tones. and making sure that they were treating their patients with respect, with dignity, and really understanding their needs. So they installed a mirror at the desk, so that basically the person answering the calls could check to see, did their facial expressions match their tone of the voice, to really give a sense check of, are you really trying to, support this patient and personalize that experience? And I love that. And then finally, a project that we're involved in the Roche that I'm really excited about is we've partnered with a digital startup in the UK called Give Vision, and they have a visual acuity aid that's been demonstrated in Marsden Hospital in the UK to improve visual acuity for a number of people close to becoming blind. And actually, what they've started to do now is wonder whether they can actually now turn that into a diagnostic tool as well to do visual acuity scores and maybe even replace the optometrist. And could they then send alerts to physicians to maybe increase or reduce doses of maybe anti-VEGF therapies? And really, that's a study now that we will conduct in Thailand to see if we can validate that performance, but also at the same time, improve the quality of life for people with very low visual acuity. So I would say, as I started off, there is some great hope for Thailand, and the future is definitely here. It just needs to be more evenly distributed. Thank you, Charles.
Wow, thank you, Farid. You did make me smile when you were talking about the radiology and the use of AI, because we tend to forget how many years we've been playing around in this space. If any of you have a spare minute one day, just Google paging Dr. Pigeon in your search engine, and you'll get an article from the New York Times from the 25th of November 2015, where they were looking at the effect of having a pigeon assess mammographies in terms of tonal colors, and they compared that to radiologists and found, perhaps not surprisingly, that the pigeons were as good. Of course, they couldn't treat people, and of course, they couldn't assess. But in terms of color determination, they were the same. It's quite amusing. I would suggest you have a look at it. Thank you. Let's now move on to the final presentation from Shyong. Over to you, Shyong.
Well, thank you very much, Charles. And Chai and Farid, thanks so much for sort of setting the scene for this sort of last piece. Brendan, maybe just take me to the next slide, please. So one of the big challenges that we face today, and I sort of started off talking about sort of diabetes, is that there has been a transition from illnesses that are very acute, right? Things like infections and accidents, to illnesses that are very chronic as the major source of burden to both the healthcare system, but also to the quality of life of the people living in our countries. And a lot of this has to do with socioeconomic development and increasing age of the population. But I think it's really important to recognize that these two situations are very, very different. So if you look at Singapore, you might get the impression that this is a very advanced healthcare system, but you have to remember that the healthcare system was built in the 1970s, which is really not that long ago. And at that time, the main chronic disease that people needed to treat was tuberculosis. And when you treat tuberculosis, if you take your medication regularly and you finish the course, the chances are the disease will go away. So the traditional model of healthcare is for people to have these acute illnesses, come to a healthcare system, get treatment, and then eventually they're cured. And in that paradigm, we talk a lot about sort of quality and safety. We talk about evidence-based care and clinical algorithms. And increasingly, we talk about these sort of systems and value-based care paradigms, which are really about cost effectiveness and minimizing the cost of the healthcare system so it doesn't run away. And we talk about things like access. Does everybody who needs to see a doctor actually, are they able to see a doctor, and can they get an appointment and can they pay for it? I'm not saying that any of these things are unimportant with chronic disease. What I'm saying is to sort of use an epidemiological term, these are things that are necessary but insufficient. And the reason is because when a person with a chronic disease comes to a healthcare system, the first thing that's different is that they don't feel unwell. Very often they don't feel unwell. And then they come in and they get a treatment. And actually this treatment is very often tied to self-management. So we've heard Farid talk about lung cancer and maybe, you know, cigarette smoking in Thailand, for example, or the consumption of certain foods that drive certain types of cancer, for example, in the biliary tract. And they go around in this cycle of treatment and self-management for many years until eventually they develop complications. And they still have to sort of treat and self-manage themselves right until you reach the end of life. And what that means is that these individuals have to commit to a lifetime of treatment and self-management. And it's very different from an acute illness. And I think this is important. Next slide. So this is a drawing that was produced by a patient at a World Cafe event, describing what it is to live with a long-term condition. And what he's drawn for you, or what he or she has drawn for you, is first of all this green line. And this green line reflects the ups and downs of their life, right? So that when it's up, maybe they had a sort of nice, happy event happen. When it's down, maybe their relative got ill or their dog died. And you can see them sort of going through their lives and experiencing these ups and downs. And these orange lines are actually the regular doctor's visits that we organize. And you can see that sometimes we're there when they need us, but in fact, most of the time we're not there when they need us most. And the example at the bottom is at the bottom, right? So if you think about the number of hours in a year, that 8,756 hours in a year, if you have a chronic disease in Singapore, you probably spend no more than 2 to 4 hours of that year with your healthcare provider. And what that means is that for the other 8,752 hours, our patients are on their own. And I think this is really, really important. Next slide. And what that means is that when you start to think about chronic disease management, all the things that we said were important for acute illnesses are still there. It still needs to be accessible, it needs to be timely and efficient, it needs to be evidence-based, it needs to be cost-effective. You need to have these IT systems and interoperable systems that allow data to move around. And you need to have sort of facilities that can support the care of these individuals. But it's very important that when we deploy these therapies and these options to the patient, they take place in the context of a shared decision between the patient and the provider. And the way that we talk about what we do in chronic disease today is the following, that we need to transform the traditional clinic consultation, which is typically a prescriptive one. Patient comes in, I tell them from a biomedical perspective what is wrong with them, and I give them the treatment that is most appropriate for their illness, maybe considering the genetics. How do we transform that prescriptive consultation into what we call a meaningful conversation, where they can develop shared goals together, they can develop strategies to implement and implement changes in their lives to achieve those goals, and eventually give rise to different to better health outcomes. So what is this? Why is this important, and what are the fundamentals? What do I feel are the fundamental things that prevent us from doing this? Next slide. So it turns out that productive conversation is incredibly important, because if we expect them to self-manage 8,752 hours a year, people have to be motivated. They have to want to change the things that need to be changed. And I like self-determination theory as a way of describing this. But self-determination theory posits that we do things for a reason, and that's motivation. But that motivation falls across a spectrum. And on the very far left, what we see is for somebody who is completely unmotivated. So they really have no reason to do anything. You're not going to get any change in those individuals. The second, but what you see once you get into the red is somebody who can be motivated, but very often the initial motivation is external. It's because the doctor told me to, or my mother told me to. And you see a lot of this in the digital space too. We see reward systems, we see nudges. I consider all these things as sort of external motivators. And I think, again, they're important. They help us form habits. But ultimately, what we need to sustain a change throughout our entire life is for that motivation to shift from something that is largely external to internal and intrinsic. I'll give you an interesting example of this because we've been doing some work around physical activity and why people exercise in relation to the prevention of diabetes. And it's very interesting because when you ask people who haven't started exercising, they very often tell you, I started because I was worried about developing diabetes, so I started. But if you ask them why they continue, they tell you, I continue because it gives me a sense of satisfaction and I feel physically much better, and I'm afraid that if I stop, I will lose that. So I think it's really, really important. And that's a sort of classical shift, right? From something that is primarily extrinsically motivated to something that is intrinsically motivated. And the chances are this person will now go on and do this for the rest of their lives. Next slide. Now, self-determination theory posits that you can only see this shift from extrinsic to intrinsic motivation if you fulfill three basic psychological needs that every human being has. The first is competence. They must feel that they're able to do it. So for somebody who's never walked more than 100 meters down the road to get a bus, getting them to start running marathons is something that they don't feel any competence for. We need to build in systems that allow them to achieve these things one little thing at a time. That's relatively straightforward. They must have autonomy. Right? They need to feel a need to control, the ability to control the course of their lives. And very often when patients come into the clinic, we tell them, this is what the evidence is. This is the best therapy for you. You just go and do it. And we take away that autonomy. Sometimes that works. When patients are very sick or they're very frightened or they're in pain, actually, they don't want you to ask them, what kind of treatment would you like? They just want somebody to take them by the hand, look them in the eye and say, don't worry, I've got this. I'll take the pain away, right? But when it comes to a healthy individual and you're talking about prevention, you need to think very much about how you can actually promote autonomy so that they can begin to develop some of their own motivation. And the third thing is relatedness. These changes must have meaning to the patient. We often talk about patients who are non-compliant, non-adherent in the clinic. And I find that that's just such a terribly derogatory term, because the question that we should be asking ourselves is what reason have we given the patient to be adherent to the treatment that we prescribe? A better way to think about it is perhaps to think that any non-adherence or non-compliance is simply a reflection of a failure of the healthcare system to engage the patient in a meaningful way. Sometimes it has to do with the person that they're speaking to. And I think that's why these conversations are so important. So Farid showed you a picture in the Siriraj Hospital where digital platforms were being used, but the success was very much reliant on a face-to-face consultation with another human being who is paying attention to the kind of body language that they're using and showing empathy. Right? Another way of thinking about relatedness is meaning. So, Charles, when you asked Chai at the beginning, why do you do this? It was interesting because Chai was Director General of Health, but he didn't give you a healthcare reason, did he? He said, I do this for my granddaughter. Right? And the question really then is, how do we make the things that we are expecting people to do? How do we get people to change their diet, engage in preventive health? Right? If we don't even understand what are the things that make them get up in the morning, right? What are the things that will make them continue? So I think we need to sort of fulfill these needs. Next slide. And when you don't fulfill the needs, and I'm showing you an interview now, a series of data from a series of interviews that we've done with patients living with chronic disease. And this is how they describe it. And I'll let you read it to yourself, but essentially they don't feel competent, they don't feel in control. And you know what? They don't feel that anybody's bothered about what their aspirations and needs are. And you can see that when they describe their ideal experience, the first thing that they say is that my care team knows what my values and my priorities are. They don't say, I need the care team to know what my blood pressure, what my cholesterol, and what my blood sugar is. I don't need my care team to know whether I smoke or not. They want the care team to know what my values and priorities are so that they can help me achieve those values and priorities. Next slide. So here's my concluding slide. We describe these powerful interactions or powerful conversations as delivering person-centered care. And I'm very specific about that definition. This is not necessarily just organized by your genotype, organized by your, by what's happening biologically inside your body. This is a biomedical psychosocial construct, and it requires you to provide care that is respectful of the patient and responsive to the patient's needs and aspirations. And if you don't know what their needs and aspirations are, you will never be able to do this. But I would also say to you that person-centered care is empirically personalized and is absolutely critical if you're going to do prevention. Because if you don't, because people's aspirations are maybe very different when they're well and thinking about prevention than when they're sick and needing to relieve some symptoms or worried that they're going to die. I think there are significant challenges in implementing this. Healthcare professionals themselves don't feel competent to deliver some of these things and have these conversations. They don't necessarily have the communication skills, right? And Farid, again, I'll go back to the example. It's such a beautiful example, putting a mirror in front of somebody so that they're aware of how effectively they're communicating is so, so important, right? But also healthcare systems ask the question, if we're going to ask these questions, if I'm going to find out that this guy wants to live for longer just because he wants to see his granddaughter get married and go to, and have children, I have to ask that question. It takes time. And the vast majority of healthcare expenses today are actually spent on manpower. So how do I measure the return on investment for that? So I think that that's a big challenge too. And I also want to finish off with this idea that digital solutions can really help fill some of these gaps. It can fill the skills gap by actually delivering content that doctors or providers are uncomfortable doing. But it also allows you to do stuff outside the clinic and collect information about our patients, about what their aspirations might be, where they want to go in life, and have that done before the clinic so that you can use the very short time you have in the clinic for these most important, most value-added conversations. But there are also challenges, and I think this is where the research needs to go. One of the things that I've tried to do in the last 10 or 15 minutes or so is really sort of to reflect back things that Farid said, things that Chai said, and the things that Charles sort of pointed out. And that demonstrates to them that I'm listening, right? And the and the question I think that you have to ask, that we're forced to ask ourselves, is what does empathy look like on a digital platform? How do we know? How do we convince people that we're listening, right? And short of using it simply as a channel for communication, what are the kinds of tools, what are the kinds of technologies that we can put in place? If we use media, what kind of subject material can we use in order to sort of convince patients that they're interacting with a human being that is almost real and is a little bit like, begins to have some of the characteristics of that operator or the nurse talking to them on a digital channel with a mirror in front of them. So I'll stop there, and Charles, you can ask whatever questions you like.
Thank you. Shyong, that was absolutely wonderful. Again, we had a description of activating people, activating citizens, delivered so beautifully. Thank you. That was really great. So we have had 3 really good interventions. Now, let's look back for a second at the poll, because I'm going to ask each of the panelists what they thought of the results of the poll. And you recall there were 3 potential answers. The first was research and real-world data and evidence, 44%. The second was data access and interoperability, 35%. And the third was digital healthcare solutions like telemedicine, 21%. So let's start again. Let me go to you, Chai, and ask you, what do you reckon of these results? What do you think?
Charles, so initially when I looked at those 3 options, I was gravitating towards data access and interoperability. But as I was listening to the presentation, funny enough, I was gravitating towards research and real-world data. So to see that is now probably pulling the highest, so resonates with me.
Thank you. Could you put your video on? I'm not sure it's on, or if it is, I can't see it.
Here we go.
That's better. Good.
Yeah.
Thank you. Thank you. Let's now move to Farid. What do you reckon?
So I would have voted if I were on the force ranking with the majority, right? And the fact that, you know, evidence really does drive change in policy, change in clinical decision making, in terms of how we think. But I think we've got enough, Charles. I think, you know, we can look at the bedside and the laboratory and, you know, all of the experiments, but we need to really accelerate that and move that into clinical practice. And in fact, the one thing that wasn't on there, but which is what Ty alluded to, actually related to the fact that actually it all comes down to attitude. And the one thing that's going to drive personalized healthcare is do we have an attitude to really think about, instead of thinking about patients, which are people with disease, by the way, if we start thinking about clients or customers, then we would interact totally differently. And I think that's where we need to move. And if we change that mindset, for me, that would be the biggest driver, other than any of those three things.
Thank you. Shyong.
So Farid used the term mindset to describe something that I call values and culture. But I think it's absolutely essential if you're going to sort of do prevention, and maybe it will apply when we think about this. But the terminology, it's taken us a couple of years to sort of coach ourselves to do this, even in the unit where I work. So we no longer talk about people as diabetics. We talk about them as people living with diabetes. Because there were people before they had diabetes, and they continue to be people after. So I think it's really important. I think all those three. I think the fact that there are no zeros across those three are very meaningful. It tells you that all those items have some value and can add value in the ecosystem. But I think it also tells you that different stakeholders have different needs. So the policymakers, I mean, they need to balance the budget this year, right? And so they need the real world evidence, and they need the cost data, they need the data on cost effectiveness. And that's why I've made a very clear point to say that none of this, everything that I've said doesn't diminish the need for the evidence. We have to have that, we need to put that in place. But actually, the person who's the recipient of this preventive health, actually, in my mind, I don't think they need the real world evidence. They don't need to know that what's being done to them, you know, cost $20,000 per quality adjusted life year. They need to know that this person actually cares about me and understands me, and is going to help me achieve those goals. The digital platforms and the interoperability has a great deal of impact on reducing friction, but it doesn't go away from this idea that the healthcare system must have this mindset that these individuals are people that they have lives, and that we need to make sure that we empower their lives.
Thank you. And you just brought me back, actually, Shyong, to the days when I was a medical student. I nearly left my medical course. And what triggered it was one afternoon where I was asked to bring in the diabetic, and I got so angry. I got so angry about the medicine by body part that we were sort of practicing in England in the 1970s. I thought, that's a human being. He's not a diabetic. He's a person. He's got aspirations. He's got family. He's got worries. He's got the taxman's after him. He's overparked, whatever. But the attitude really upset me. And I thought, no, I'm going to do something else. But perhaps fortunately or unfortunately, I stuck the course. But thank you for that. That brought a lot of color. So before we start our little panel discussion, because we have a little bit of time, and it's extraordinary how time passes quickly when you're having fun, but we're actually eating through our time really too quickly for my liking. Could I just ask the audience to please remember that they can and do have an opportunity to ask questions, and we'll try to leave some time at the end. We already have a corker of a question to start with. 4 questions at the end. So let me start with just asking a few questions. I'm going to ask each one of you individually, because again, because of time, I don't think we have enough of this. Let me start with you, Farid. And you were talking a lot about personalization and Thailand. And you sort of mentioned one or two examples, but giving us a little bit more in the way of examples, I think really would help. What's really going on in Thailand?
So I think there's a lot of startup communities, a lot of young entrepreneurs who are really trying to understand how they can get involved in the healthcare space. I think the access environment is very difficult because, whilst I would say that the innovation, the demand drivers are there, and one of the biggest demand drivers there is obviously COVID, and we've seen some remarkable things during COVID, and people just got things done. Yeah, there wasn't this big worry about evidence or research or testing. It was literally minimal viable product mindset. Let's just get it done and let's see what happens. And I think that's been great. We've seen that internationally. As I say, there is this desire strategically to move. I just feel that it needs to move at a faster pace. And, healthcare tourism is huge. So, for example, tourism in general contributes to 20% of GDP for Thailand. And healthcare tourism is a huge, significant driver. And in fact, if I look at the participants, we've got somebody from Bumrungrad, which is actually one of the largest international hospitals across Asia and serves patients internationally. A lot of their revenue comes from people from Myanmar, in fact. And actually, with the COVID situation and with the situation that we find ourselves in politically at the moment in Myanmar, then hospital tourism has taken a break, specifically from Myanmar to Bumrungrad. The challenge is that you can rethink and redesign those pathways of care. And in fact, we've been speaking to them, Charles, about trying to harness technology such as subcutaneous oncology forms, so they could teleconsult and deliver at home, in Myanmar, and harness healthcare practitioners to do that and really personalize the service. Now, there has to be a desire to want to personalize the service. There has to be a desire to want to change, and this isn't just specific to Bumrungrad. We have a lot of international private hospitals in Asia. Or do you want to keep the status quo? And do you want people to keep on getting on planes, coming to hospital, staying in a nice hotel and seeing the consultant? So unless we start rethinking business models, unless we start thinking through healthcare, then we're not going to see the shift. But I think there are positive signs, but mainly from the startups communities. I think government, big business really needs to commit to the change.
Thank you. That's a wonderful couple of examples we have. Let me now move to Chai. You're talking about, you're a policymaker, of course. Your role in government was as a policymaker. And you talked a lot about global dialogue as well. So really, could you just expand a little on the role of government around in this space? And also perhaps touch a little bit upon metrics that drive health and care, a particular hobby horse of mine, because our metrics, of course, drive volume, not value, and really looking to perhaps doing something in terms of the metrics that drive health and care.
Yeah, let me start off with the role of government. I think that the conventional thinking is that we can't do anything substantial change without getting government on board. And I think that is in principle correct. But I think that my own thinking, particularly in the last couple of years before I left and certainly after I've left, is that I think that the reality is that governments are not reformers. Governments are not innovators. Governments actually, in the end, are actually followers. So it is important that government eventually come on and actually support all the entrepreneurs and all the innovation and the people behind the research. But I think that there's a fundamental flaw in terms of how we still think that we can make progress with our innovations and for the startup. I've lost count of how many startup people that I talk to when I ask them the question, so who do you hope will be your biggest funder inevitably the question is the government. And my best advice always for them is, I think you need a plan B. And the reason is that governments are not risk takers. Policymakers are not risk takers, sad to say. But they eventually will come on board, but they will only come on board after they have watched other people take the lead, take the risk and make the mistakes. Because eventually, when you look at government, particularly politicians, because governments basically, you have two arms. One is the political wing, and then secondly is the public service. On the political side, these guys are all about votes. Anything that is going to be an embarrassment and therefore taking risk is actually is something that's an impact for them. They are very adverse to that, unless the public service, the bureaucracy, can actually convince them that a lot of those risks can be mitigated. So role of government in terms of personalized healthcare, I would say they are followers. So my advice there for those who are pursuing this is we need to look for other networks outside government that will perhaps be the vanguard and the pioneers and generate the data and the evidence that eventually will be so compelling that government will have to follow. So that really kind of takes me to your second question, Chance, around metrics. So I think, by the way, governments love metrics. They love to measure stuff. And even now with COVID, I look at all the numbers. Most of them are completely meaningless, but the politicians and the bureaucrats keep rolling them out. But I think but it is important to measure. So particularly around something so new like personalized healthcare, I think that it's really important that we don't get so obsessed with whatever initial basket of metrics that we come out with, because the important thing about metrics, it allows us to have a conversation. It allows us to ask more questions. I think that is actually the role of the metrics. But so often, I think people get lost in the data and in the arguments around which matrix is better. So I hope that makes sense to you, Charles.
Yeah, it certainly does. Thank you. Thank you. Shyong, your question really is I'm going to follow the same theme, of course, as in your presentation. You were basically describing activating people and incentivizing. And I'm going to go back to the incentivizing and gamification, really, because you've been doing some interesting stuff in Singapore around gamification. Could you just expand on that a little, because other countries are doing quite a bit of this as well now. You're not alone.
No, I think it's useful, and in fact, one of the things about video games is that if you play them, you realize that what's happening is that they don't make you go to the final stage right from the start. You sort of go one level up at a time, and you acquire new weapons or new devices or new skills, and then you're able to do a little bit more, and then you go up one stage at a time, and then you get past these stages. What they're really doing is recognizing that competence and self-efficacy is really important to keep people engaged and motivated. So I think it has its place. But I do think that a complete focus on extrinsic motivators may not give rise to sustainable changes that prevent chronic diseases.
Okay, absolutely. In other words, it's a nice little nudge to get the engine going, but unless you have inbuilt sustainability, you'll either run out of money or you run out of impetus to do it. Absolutely. And so will the individual. Perfect. Now, we don't have much time, sadly. We only have less than 10 minutes, and we have two crackers of a question. The first question, really, I'm going to try to ask is really more to Farid and Chai, because I've got a second for Shyong. So the first question really is, why does evidence imply clinical or financial measures? Do we have sufficient evidence about consumer satisfaction, what citizens want from the healthcare system and its providers? I voted for more research in the space of understanding what motivates people at a population level to engage in their well-being when we have trained them over decades to let the doctor decide what's best for them. So it's more of a statement, but it really opens you up to commenting on it. Chai, start, and then I'll move to Farid.
Yeah, so yeah, I think the person has actually touched a very relevant point around evidence, and in fact, when Shyong was speaking, and he was talking about empathy, and one of I suspect the person who asked the question is leading down this particular road. I think that for too long, the evidence that we're looking for is the clinically based oriented evidence or the financial ones, right? Because when you kind of look at things that are much more complex, like chronic disease, sometimes the evidence is not quantitative. Sometimes the evidence is in the narrative and in the storytelling. In fact, sometimes the person going through with the chronic disease don't know. So they actually have to spend some time discovering what is actually going on within themselves. So when we look at the whole realms of evidence, moving beyond the qualitative, whether it's the clinical or the financial or whatever, towards the much more, it's the quantitative, moving towards the much more the qualitative. And if you like, reading between the lines of what has been spoken, because on complex issues, the people who are articulating the so-called evidence may be trying to send signals in between the lines. So I think that that's a really good question.
Thank you. Thank you. Farid, your take on this?
Yeah, so I think we do have healthcare systems that recognize the patient voice and patient feedback. I think in the NHS itself, Charles, we have the friends and family test. We have those type of measures quantitatively that we can really look to, and we inform, patients to really rate our services. But going back to Chai's point around, what's behind why they rate those services is what's missing. And there's different ways of getting that. One of the things we use in our industry, and from a market research point of view, we will use things like web scraping of social media. So we really understand and pick up those intrinsic values and that, that non-quantifiable data, and really make sense of what is the qualitative data telling us. There are other things to do. We run patient advisory boards, right? Solely to understand and help us understand how we can do better. When we have leadership team meetings as a pharmaceutical company, we have a role which is voice of the patient. And in fact, we invite patients in to look at our strategies and our plans. We involve them in decision making because ultimately we want to serve them. So it's around mindset, and it's around really making sure that you really focus and you value that voice of not the patient, the person with disease. And then really think that through. And if that's in your DNA and you build that in your DNA and that matters to you, then there are multiple different ways of collecting that insight.
Thank you. Thank you very much, both of you. Let's now move to the second question for Shyong. And really, to a degree, we've answered bits of it. So the question goes, for people who have yet to show symptoms for NCDs, how do you measure the risks, create personalized risk reduction pathways, make the end user understand this and motivate them about the care plan to reduce the risk? And obviously, I'm not going to ask you to answer all those questions in, you've got about 4 minutes if you're lucky. So just forget that. But in essence, I love the question, of course, because it takes us into the lifelong approach to the managing of non-communicable diseases, where symptomatology happens, really, but of course, people are not diabetic and suddenly become diabetic. There is a transition here. And the lifelong approaches to risk reduction is really, I think, what we're talking about. Shyong.
I don't know if I have the answer to this question, but I can tell you what we are doing. I don't think that the challenge is in measuring risk. I think there are hundreds of risk tools for evaluating the risk of diabetes and cardiovascular disease. I think the challenge is in communicating the risk in a way, in a meaningful manner to the patient. So we take our risk we develop our risk communication tools with patients. We wander around in Singapore, the hawker centers and the rest, you know, and talk to people, show them different sort of things, and ask them, do you understand this? What do you understand by it? Would it make you want to do something? The second thing is this question about creating the personalized risk reduction pathways and making the end user understand this. We usually follow that up, and we do this in the clinic now, but also on our digital platforms, immediately with a question: what's important to you? And it usually has nothing to do with health. Is it your family? Is it your job? Is it meaningful interactions? Is it giving something back to the community? And then what we begin to do is to sort of begin this process of matching what might be helpful. That's my domain. That's the stuff that I know as a doctor. This can help, but we're trying to sort of match them now to their natural aspirations. So if you had your health, if you did not have diabetes, what would you be able to do with your life that you wouldn't be able to do if you did develop diabetes? And that, we think that conversation is very, very powerful, and we're trying to sort of develop a series of digital interaction tools to sort of enable those conversations. And then what it means is that, and then what we do is we provide the skills, so that's the competence, but we also provide some choice. Here's a few things that would help. Why don't you choose one? So we're also, you know, promoting autonomy, though all those psychological needs that underlie the ability to transition from something that is purely extrinsically motivated, I don't want to get diabetes, to something that is intrinsically motivated. This is how I want to live my life. So that's what we're working on. I don't know that we have the solution. We have some prototypes in play, but you know, I think it's a great unanswered question.
Thank you. And in many respects, Shyong, I think this is really important, because what has been until now really a rather unusual way of managing people's lives, which is really what you are attempting to do, is now becoming more and more mainstream in more and more countries. As I travel the world, sadly, figuratively at the moment, but soon in practice again, in reality again, it's become very, very much more obvious that all governments, all processes, you know, all systems are starting to think much more about this lifelong approach to non-communicable diseases, and also using digital transformation as the key to blend the service from the episodic approach that you showed in that little vignette. So, of course, sadly, we're out of time. So what's the surprise? We have 1 minute left, and I'm thinking I want to use that minute. So why don't you give a single thought to each of from each of you, please, to the audience in terms of a learning point, a single learning point, hopefully no more than a sentence or two. Please, Shyong, let me start with you and go the other way around.
I'd say technology needs to be placed in the context of people's lives.
Thank you. Sorry, I sprung this on you, of course, all of you. Farid.
Let's start thinking about people with disease as customers or clients. Let's think about personalizing healthcare rather than personalized healthcare. And if you think about that, personalized healthcare will follow.
And Chuah?
I'm just going to follow Shyong a little bit. I'm going to paraphrase from a German colleague. In this day and age where we are so obsessed with technology and digitization, I think it's very important we have people who have a caring heart and the warm hands.
Oh, what a wonderful way to finish. It's such a pity we only had 75 minutes, and really we needed 150 today. So can I thank all the panelists? We've had some fun. We've had a wonderful conversation between us, and some people were listening in. And over back to you, Brendan.
Thanks so much, Charles. And thank you all for joining our discussion today in personalized care. If you have any questions or would like to learn more about Roche and what they do, please feel free to contact us for more information as shown on the screen. Everyone, take care and stay safe. Goodbye.